Good afternoon, everyone. Thank you for joining our webinar. We'll be getting started shortly. Hello, Gloria from Butler, PA. We got your message and hope that you will be able to hear everything loud and clear.
Everyone, I'm going to stop sharing the screen just for a moment so that I can go live on Facebook. I will be right back.
Well, good afternoon, everyone. We wanted to go ahead and get started. We know that we have action-packed series today, and so we want to get started. My name is Dr. Kathy Elliott, and I'm the CEO of Gwen's Girls and the convener of the Black Girls Equity Alliance. It is an awesome opportunity for us to be able to bring this upcoming webinar to you. And it's a series that we are looking at the inequities that Black girls face here in our area. And it's an extension of the work that we've been doing through the Black Girls Equity Alliance. Quickly, I want to give just a history of the Black Girls Equity Alliance. It was formed after a summit that we held in 2016, in which we focused on the inequities that Black girls face here in Allegheny County. And we also started to look at not just what was happening with the girls in our particular program, but what was happening in the system. And so from a report which was entitled The Inequities of Black Girls in Allegheny County, we formed an alliance following the summit that focused on 4 areas: the education system, the juvenile justice system, the child welfare system, and then also health and wellness. And so one of the issues that you will hear today that we cover within the health and wellness work group is looking at comprehensive sex education. And one of the things we had started to build these webinars out a few months ago about what topics that we wanted to discuss, and COVID-19 hit. And so we knew that there were issues that were happening prior to COVID-19, but now it has exacerbated a lot of the issues that we know that our girls face. So we wanted to not only talk about what was happening historically, but then what is happening today, and what are some of the strategies that we can employ to try to mitigate some of the trauma and the issues that our girls are facing. So we have some great speakers and presenters with us today, and I just wanted to just say thank you all for being here and tuning in. So Tashara, if you can maybe go to the next slide. So as you see, it has a list of the panelists, and I'm not going to take time right now to go over each of the panelists, and we will throughout the presentation give an introduction of who these people are. But I also wanted just to take time to say thank you very much to our the funders that have made this possible for us to bring these webinars, as well as the support that has occurred over the years through the Gwendolyn J. Elliott Institute. The Heinz Endowments, FISA Foundation, and Opportunity Fund have been just partners in this work, not just financially, but also the leaders of those organizations have been very integral in addressing the inequities that impact Black girls. So thank you very much to those foundations. You heard me talk about Tashara, and I wanted to just mention that she and we don't have slides with our information, but Tashara Heller is our research coordinator through the Gwendolyn J. Elliott Institute, and you'll get a chance to meet her as well. But she is my co-facilitator in this process, and so thank you, Tashara, for being behind the scenes and helping us. There also are a few housekeeping things that we wanted to go over, and one of them is that that we have some closed captioning as well as some sign language practitioners that will be joining us, and so please look out for that. And in the chat box, there'll be information on how you can engage in that if you need that resource. So without any further ado, I would like to introduce Ms. Shalay DeBlanc. Shalay is currently our clinical coordinator here at Gwen's Girls. I'm like, why am I blanking on who she is? Because she's so important to us. And she's also a clinician at A Second Chance. Shalay has extensive experience working with children and families in foster and kinship care, as well as an expert knowledge and clinical training in trauma. She is a driven and cultural responsive, progressive leader who has demonstrated continued commitment to our youth through various community initiatives. So I would ask that Ms. Shalay, make her screen visible, as well as at this point, I also want to highlight, let's see. And it's hard when we're sharing our screen. So Ms. Deaja Diggs, she is another panelist that will be talking during this segment. Deaja Diggs is a secondary education major at CCAC and outreach coordinator of Black, Young, and Educated. As a part of today's Black youth and sisterhood, she believes that their voices deserve to be heard and makes a difference. She is a former Gwen's Girls Bagala member and feels her participation provided multiple opportunities, including a voice to speak out about racial and sexist hardships Black women face in everyday life. So Aja, welcome, and thank you very much for being here with us as well. And we wanted to start, as we have our other webinars, with youth voice. And so one of the things that we know during this COVID-19 experience, and I'm calling it an experience because it is just from beginning, from the time that we, initially learned about it in February and March until today, it's been something that has impacted our lives on many different levels. And we still don't know what any future impacts will be. But we know that mentally and psychologically, there is some, ramifications that are happening. And so to be able to cope is one of the things that we know that is necessary. And so what I would like for Ms. Shalay and Aja to talk about is just, what has been their experience over these past few months and how they have been able to cope during these past few months personally, as well as, young Black women, navigating different systems and just life in general. And then we certainly want to uplift the issues that have been happening around our country, around the social and racial justice unrest and issues that need to be addressed. So I'm going to quit talking. I'm going to hear from our experts, our young experts. So Aja, as well as Ms. Chalet, can you please, give us your insights?
Absolutely, Ms. Aja. I'll go ahead and start if you don't mind. So, hi everybody. I'm delighted to be here, but I just kind of wanted to take a moment and talk about just some of the things that we know are plaguing Black girls and are plaguing the Black community and people of color. And obviously, there's a disproportionate, just kind of a disproportionality, and there is also disparity when it comes to social and economic divide, and when it comes to access and different things to healthcare, to mental health care and things like that. And so we know that these things kind of plague the health outcomes. They contribute to our poor outcomes, and they also contribute to the stigmatization of just mental health as a whole. And so culturally, we know that people of color, they don't really love mental health and things like that. And so when we went from a model where everybody was face-to-face and we had this big transition into what is now virtual and telehealth, there was this big cloud hanging over everyone's head to see if there was going to be that kind of buy-in and that kind of interaction virtually and online. But what we've actually found is that more people want to do online mental health, which is awesome. But even with that, COVID has been tough. It has been a lot. And what I found as the clinical coordinator at Gwen's Girls is that we didn't just have COVID happen to our children and families. We also had COVID happen to our staff. COVID happened to our homes personally, but it also happened to us professionally. And so in my experience, it wasn't just something that we had to troubleshoot with our children and families. It was something that we had to sit with the staff and kind of redefine and figure out what our new normal was going to be. So I'll start with the children, of course, because they matter the most. I will start with our children, but in that, we understand that there is a lot of homelessness. There's a lot of trafficking. There's a lot of depression, anxiety, and different psychological and health issues that are affecting our adolescent youth, specifically our Black girls in our community. And kind of with that, we also have to take into account our inaccessibility to insurance, our transportation issues that we have getting to and from the doctors, our issues that we have with loss of income. So we do have a lot of kids and a lot of adolescents who work. So take Bagala, for example, we have our high school students who were excited about working and everything like that, and they may be contributing to their household, but we know that majority of people of color, majority of African Americans in our area and other areas, they go into the social service industry. And with that, social service industry jobs like retail and restaurants and different things like that, like hospitality, they actually lost their jobs first. So what are those mental health implications that you have for people who may have been contributing to their household, but now they lost their job? Their parents also lost their job. We talk about social distancing. Social distancing is everywhere, but what about the people who could not afford masks? What about the households and the families who can't social distance? Simply because it's a generational thing, so that we know if people of color are living in public housing or if they're living in low income housing, typically they live with all of their family. So they're living with grandma, they're living with mom, they're living with siblings. There may also be dad and cousin. There may be a large group of people in the house, which makes social distancing nearly impossible, right? Especially in low income housing. And so these are just kind of different things that play into mental and emotional health and the psychological well-being of people. And it's an understanding that just because somebody is not exhibiting psychological issues or mental illnesses or problems, like the absence of these mental illnesses and emotional breakdowns does not mean that someone is well. It doesn't mean that their well-being is intact. And so a lot of times different things fall by the wayside. And even if we take it a step further and we add in what Dr. Kathy kind of explained with the police brutality, and I would take it one step further and add, because we all know what police are doing to Black men, doctors are doing to Black women. So if we take it a step further and we add that into the pot, what does that do when we have kids who have bodies that are changing, who need appointments, who aren't able to get to the doctors, the virtual appointment didn't seem to be effective, or they're kind of scared about going to the doctors, or whatever the case may be, what does that do to how they feel and who they are and how we address them as people, how we address them in our households? And so all of these kind of things just play into our mental health. And we know, again, that our kids are at a higher risk of psychiatric issues and mood disorders and different things like that. And so with a scramble with school, which we know a lot of them get their mental health through school. So with that scramble and not knowing what the state of that's going to be, it is kind of one of those things that as a therapist, you kind of almost feel helpless, but feel a little bit sad. You know that you can do a great job, but you also feel sad about the fact that these kids feel helpless and that everything's up in the air. Because of course, as a therapist, I want to fix things. But the reality is the state of COVID has literally left us in a state of just disequilibrium. It's put us in a space where no one kind of knows what's going on. But I will say that for me as a clinical coordinator and working for One's Girls and working at an agency that is so prideful and definitely prides themselves on caring about the emotional well-being of our kids, caring about the mental health of our families and our staff, we have been able to incorporate what's called Sanctuary. And we are on our journey to become Sanctuary certified. And so everything that we do comes from the Sanctuary Institute, and we've embedded that in our policies, procedures, and our literal daily functioning. And one of the tools that we use, it's called SELF, and it stands for Safety, Emotion, Loss, and Future. And it's pretty much a problem-solving tool that allows us to address different issues and situations or concerns that may come up, not only just at an organizational level, but it lets us address them with children and families. And it helps us to encourage our families to self their stuff too. That makes sense. So, we're able to bring these problems to the table, so we can bring the issues and problems that we're having with our adolescent girls and say, hey, now we have an issue with trafficking, because we know that domestic violence is up. Exposure to domestic violence for our kids is up. We know that our kids being home, they don't have school, which means they're out. They get to go out with friends. They get to walk around. They end up being approached by people who are preying on kids and all different things like that. And so we bring these problems to the table, and we're able to use SELF, and we go through each one by one. So we'll put it on the table and we'll say, all right, safety, what's hanging in the balance? What's going on with the safety of our kids? What happens with the emotions? How are we feeling about it? How do we think they are feeling about it? How do we incorporate that youth voice, like with what Ms. Aja is going to do here in a minute? How do we do those things? What about loss? What are we losing here? Our kids lost a whole semester of school, right? They lost sports. They lost friends. They lost teachers who they may have felt were safety nets. They lost food. So now there may be food scarcity in the home. They lost all of these things. And what we don't do sometimes is take the time to figure out what those losses, what implications those losses have on our children's mental health. And so obviously we want to kind of look towards the future, and that's what the F is for. And, we say what we're hopeful about. We say how we can fix it. And so we come up with plans and actions, and we try to be actionable about fixing these things for our kids. And then in addition to that, we use other tools, which include safety plans as well as self-care plans. And that goes for staff as well as children and families, which is awesome. And so I really, really want to encourage you all that if you want any more information on just kind of different tools like that, definitely reach out, because I would be more than willing to kind of go over some of them with you and help you out with them. But yeah, that's pretty much where I come from with it. And yeah, I'm open for questions if you have any questions at the end.
Thank you, Shalay. And what I want to do is I want to get to Aja, but then I also want to come back to you again to just rehash and go over some potential solutions and strategies to mitigate the loss that you talked about, as well as just some of the mental health issues that people and supports that people need. So Aja, how are you today?
I'm a little, a lot of emotions, a lot of thoughts in my head, a lot of processing has to be done. But overall, I'm okay. I could say that I'm doing better than I was before. I'm okay.
Okay.
But speaking off, by the way, my name's Diogene Diggs. I go by Aja. I'm a former Magala alumni, and I am a CCA student. in secondary education. I'm also the coordinator of Black Young and Educated for outreach. So basically, I'm an advocate for youth voices, and speaking off of what Ms. Chalet said, I feel like everything's relative. These past couple of months, there's been a lot of change, and good and bad, mostly bad, but it's coming there. A lot of change, a lot of wokeness, a lot of eye-opening, especially for me, realizations. Ever since this COVID situation has been going on, I have a younger sister, she can't go to prom because everything's closed down, and the kids are just very upset and feeling scared of what the unknown is. We're afraid of the unknown. We don't know what this sickness is. We don't know what it can do to us. And there's been a lot of racial disparities when it comes to deaths with this disease. A lot of Black deaths has been the ratings are high. But going off of what's been going on these couple months, there's been a lot of Black power, a lot of Black unity, a lot of spreading awareness and activism, even within social media. We don't have, back then there wasn't internet and stuff, and we have social media now, so we can spread awareness, building off of whatever is going on in the world. There's been a lot of protesting, a lot of hurt, a lot of empowerment and rejuvenation, and a lot of kids learning about what being Black truly means to them. And a lot of Black women are realizing what being a Black woman truly means to them, as well as me. So I'm not getting emotional. As we know, Breonna Taylor was murdered by 3 policemen while she was asleep. And that has been a conversation ongoing. There's no stopping. There's been protesting. The people are angry. There's going to be revolution. There's going to be change, and the people are angry. I've been talking to a lot of Black girls about how they feel about Breonna Taylor, because I feel like the Black woman is the most disrespected person in America, as Malcolm X said. And we've just been talking a lot about how to process those feelings and how to process those emotions. And a lot of Black children are afraid to even go outside and be children. You can't go outside, even with this COVID thing, you can't go on the porch and play in the front yard. You can't take a walk with your friends. You can't go to the playground and enjoy your life. And that's very scary for Black children to be I can't even go outside or I might get shot, and it shouldn't be the new normal. Our children shouldn't be afraid to go outside and be children. Our youth shouldn't be afraid to live their lives, and they shouldn't be afraid to leave the house, and that's what I want to advocate for. I know so many youth, they don't feel hurt with what they're concerned. We're used to the adults taking the lead. We're used to someone else doing it for us. But like I said, there's been change these past few months. If no one's going to do it for us, who's going to do it? So I took the chance to step up with BYE, and I used the information that I've gained from speaking and being a part of a gala, and I'm using that knowledge to spread awareness and educate others on what's happening. And I want to give children an idea of what Black liberation truly means to them. Black liberation, we want to be free from all these different bills. We want to be free from all these different rules. We want our rights. We deserve to be heard. We deserve to be protected. But here's the thing, who's protecting us? Black women, who's going to protect us? We stand up for everyone else, but who's going to protect us? So it's just amazing and very empowering to see so many people coming up together. The masses are waking up. We're showing off with our activism. We're setting change. We're shutting things down. And that's something that's liberating to me. But also, speaking back on what I said, everything's relative. A lot of things have been realized. I feel like everything is built off systematic oppression and racism, especially with women being in the medical industry. There's a lot of Black women who are dying in childbirth because they feel like they're not being heard. Or we have the stereotype of Black women are strong. Meanwhile, that's very like harming to Black women because we're seen as these strong characters and we're not being felt like we're being heard. You know, there's not, Black mental illness is not being accepted within Black families in society as a whole. So people are used to like seeing like that strong Black woman, she's strong, you know, she doesn't feel hurt, pain and whatnot. And it's sad to see that a lot of Black children are not being heard, or not being nothing. There's nothing being done with it to help the depression. There's nothing being done to help with their anxiety. You know, we always have to keep a front face and always have to keep a smile on their face, but they're not having the opportunities to be able to vent about how they feel or being able to set up a goal on how they feel. And also the disparity within the jail incarceration system. There's a school to prison pipeline, you know, most Black people are being like incarcerated. And it's shocking how the status quo is. There's even like it's storming outside, but there's even like racial disparities with even working in a job. You know, hairstyles are being called unprofessional. We can't wear natural hairstyles. We are expected to fit within the social norm. And that's not fair to our Black people, sorry. It's like storming outside. But I honestly just want to give a voice out. I've been very socially woke these past couple of months. There's been so much anger built up. And I want to take that anger and I want to use it to motivate myself and others on what's going on and able to fight and speak up about what's going on. Because right now in the world, our people's not being treated the way they should. And a lot of Black women and Black men are being killed every day, especially our children. They're killing our children. I feel like what needs to be said, you know, and that in order to like say what needs to be said, we need Black unity and we need to give our children a chance to tell us how they feel. You know, nobody asks how they feel, you know, about the situation. No one's sitting down with their kids, explaining to them what's going on, you know. And a lot of our kids feel stuck and afraid to speak out and they don't feel heard. And I just want to like advocate for those who, you know, are not being heard. I hope I'm not like rambling or anything, but.
No, you're good. Thank you. And so to me, it's not rambling. It's definitely, as you said, it's the voice that we often, as adults, don't listen to, but we need to hear. And so we have been very intentional about having, you know, the voice of young people to start off these webinars, but also throughout it. So you'll hear us talk about a variety of different topics around the comprehensive sex education and what's happened with Black girls in the healthcare system. And so if anything that you want to add, please do. And so I just want to quickly ask Ms. Chalet, because you mentioned a lot of things around like what should be happening, specifically with young people, how adults need to listen to them. And so I want to ask Ms. Chalet to come back on and to, you know, just if she can just give us a few kind of pointers or suggestions, strategies that adults, whether it's parents, whether it's caregivers, there's many people on this call that work in social service organizations or work in organizations that work with children. What are some of the things that you can suggest that they start to do as we continue to address, as Aja just talked about, there's many traumatic issues that are happening and just compounding, you know, on a regular basis on our young people. And so what are some of the things that you can suggest that the adults do to try to support our young people?
Okay. So the first thing that I am going to lead with is kind of drop the whole statement that young people should stay out of grown folks' business. I know that's a statement that's very, very kind of common in a bunch of different homes and a bunch of different cultures. So because we're in the middle of a pandemic, even before, but because we have these different crises going on, we have to have adherence to, observance of, and an understanding that the kids already know what's going on. You're very much aware. And the worst thing that you can possibly do to your children is not be transparent with them about what's going on. Dancing around the actual issue because you as a parent, you as a caregiver, you as an adult is not comfortable with saying what needs to be said, as Asha said. It's not saying what needs to be said. And so now we're kind of being dishonest. We're not being transparent. And those are things that are damning to kids. Those are things that kind of bring about mistrust. And there goes the ending of communication between a parent and a child, between a child and a caregiver. And that is typically why our kids are so open to talking to other kids. Because they're honest with them. They say what's on their mind. Kids have word vomit. They just say it, right? And so we want to be honest with ourselves, but we also want to be honest and transparent with our kids. And then in addition to that, you have to be honest about what your routine looks like. And you have to recognize what normalcy needs to look like for you and your household, what normalcy is for your child. What was their normal habits prior to COVID, prior to all the different crises that are happening? What did their schedule look like? And what does it look like now? Are they eating the same? Is their hygiene different? Are they bathing? You might be like, I'm in the house. There's no need to bathe. What does that look like? What does their sleep habits look like? Those kind of things, all those things play into your mental health. Yes, I may be in the house. Yes, no one's going to see me, but yes, you still need to bathe and you need to get dressed for the day because you need to retain some sort of normalcy so that you don't blur the lines between kind of what's happening at home and what happens in the world, because home should be your safe space. Home should be your place of peace. For some people, it's not. But for a lot of people, it is. And that's what you want to maintain. And as parents and as caregivers and as adults, we want to stay engaged with our kids. We don't want to let them shut us out. We want them to kind of keep talking, keep engaging. Encourage meditation. ASMR works. I don't know if any of your kids watch other people eat on YouTube, but it's a thing. It's ASMR. But that's calming. To someone with anxiety, it is calming. Exercise, different hobbies, picking up different hobbies. If you're in the house, there are so many things to do that you can find that you do in the house. And as parents, we're either going to be emotion oriented, we're going to be task oriented, or we're going to be avoidant completely of the behaviors. And really, as a people, like, we want to be more task oriented. We definitely want to be in tune with our emotions. We don't want to avoid the situations. We want to address them. And we want to do so in a way that is in a language that our kids understand. We want to speak to our kids in their language, not in our language. We as adults can't expect them to come to where we are. Kind of not fair. And so just in that, because our kids are always on the phone, and I know anybody from Gwen's Girls is probably sick of hearing me say this, but there are self-care apps. I would encourage you to download them. And I say that because our kids are on their phones 24/7. They sleep with them. And so if your kid sleeps with their phone, encourage them to download the sleep app. It can help their sleep habits. There are meditation apps. There are so many calm apps, different apps that can help your child regulate their emotions and get in tune with how they feel. That way it'll help them to kind of process. It'll help them to express themselves to you as a parent, an adult, a caregiver, a super auntie, whatever you are. So yeah.
Thank you. So we're going to transition into the other subjects that we have for today, looking at sexual health and reproduction. And so, Tashara, if you can come on screen, and good afternoon. And if you can navigate us into these next sessions to provide any additional updates that we need to share with the people who are watching and a part of this webinar, that would be great.
Absolutely. Hello, everyone. Thank you for your patience with us as we figured out the sign language and also the closed captioning. Let me just say, as a housekeeping measure, when I share my screen again for our panelists, we may lose Jay momentarily. If that happens, please use the link that has been placed in the chat box to be able to see the presentation via closed caption. Okay, so for folks who are hearing impaired, you have both ASL interpreters and you also have closed caption as an additional service. service. And I hope that that gets us to where we should be with being inclusive. So a couple things. Also, please use the Q&A box for questions. That's how we'll know what you all want to hear more about from the panelists. Also, as you're using the chat box, make sure that you select all panelists and all attendees, if that's in fact who you want to chat with. And also text a friend who is not with us today and let them know that we are live on Facebook. So we are broadcasting via Zoom and Facebook as we speak, okay? I always like to kind of wrap up the previous conversation before we go to the panelists, just because we think the youth voice is so important. And it was two things that Aja had to say that I think really just grounded why we're here today. And the first thing is that Black youth deserve to be free. And that just really sat with me. Number one, Aja, your awareness, but number two, also what it would have to mean for a young person to recognize that they aren't free. If we call a thing, we know that white kids don't have that experience. And so that's something that is unique and as a result of systemic oppression. And that is what we're fighting against through our work at Gwen's Girls and the BGEA. The second thing is I heard Aja describe, and also Shalay, honestly, two pandemics, right? We're dealing with coronavirus and COVID-19, but we're also dealing with systemic racism, oppression, patriarchy, sexism, all the isms at the same time, which is difficult. It's difficult. And so we thank Shalay for being able to point out those mental health resources and really grounding today's conversation. So I'm going to share my screen so that we can hear from our sexual and reproductive health experts today. Give us just one moment. And we are going to hear from Dr. Brittany Brinkman. First, Dr. Brinkman is... I'm sorry, I need to move Kathy. I love your face, but you're right in the middle. Dr. Rickman is an associate professor of psychology at Point Park University and owner of BGB Consulting, which is a consulting firm for nonprofit organizations and schools. She's the program director for the PsyD program in clinical psychology at Point Park University, where she leads the social justice psychology research team. Dr. Brinkman is on the advisory board for the Gwendolyn J. Elliott Institute at Gwen's Girls, and she's also the co-convener of the Health and Wellness Working Group of the Black Girls Equity Alliance. And the report that she and Jose Garth will discuss today comes from that work. Jose Garth, who we also have with us, is an educator focused on positive youth development. He's been offering comprehensive sexual health education in the greater Pittsburgh area for nearly a decade. He's the creator and lead of Planned Parenthood's Education Department's Violence Prevention Program and the co-convener of the Health and Wellness Working Group of the Black Girls Equity Alliance. We're so excited to have you with us today. We're going to get started with your presentation, and please give me a cue when I need to change the screen.
Great. Yeah, so it's really great to be on here with all you folks. It's good to see that so many folks are interested with these topics. We just kind of want to start off just kind of giving a little bit of just what we talk about when we talk about comprehensive sex ed. For the 8 years that I've been facilitating sex ed, one of the greatest challenges I've had is really explaining how broad and the breadth of not only what we cover through sex ed or what high quality comprehensive sex ed should be, but also how much we can actually tackle with that, because it is a great sexual health tool. But even more than that, it can be really a tool for social change. We really have a way to create a culture shift, tackling the misinformation and shame and stigma that comes along with lots of issues that we deal with, as far as reproductive justice, LGBTQIA plus equality, sexual violence prevention, gender equity, dismantling white supremacy. You know, and I know Aja and Shalay really touched on this as far as some of the issues that we're facing right now. And I really feel seeing the intersection of what we can do through comprehensive sex ed is really important. And truthfully, as someone who goes to lots of conferences around this, even within the spaces of folks who facilitate sex ed, we still see kind of a race neutral take on it, a gender neutral take, where it doesn't really think of ways to tackle some of these issues. And we'll get a little bit more into this when we look at the report. But when we're looking at high quality sex ed, we're looking at something that's inclusive of all identities, and especially those folks who are identified as LGBTQIA. It's sexual violence prevention. It really allows us to tackle racial sexualized stereotypes that people of color are at great risk of experience, that leave us at a greater risk of experience violence. It really debunks a lot of harmful sexual or gender stereotypes. It really defines and promotes enthusiastic consent practices, which a lot of folks seem to be struggling with these days. And it empowers each of us to claim the right to our own bodily autonomy. So really, when we're trying to get rid of all these isms, you know, and really trying to break down kind of these patriarchal things and make these shifts, sex ed can be a really great tool for that. And I love that, you know, Shalay really brought up the issue of not just, you know, racism and sexism, but we see a lot of ageism too, where we don't allow our students to really take ownership of their body and their sexuality, and oftentimes I see people lead with shame and stigma as opposed to information and tools that folks can use to make the best decisions for themselves. So we always make sure that, you know, it's developmentally and age appropriate, really taking this holistic approach, not coming at sex ed as this, what I always call below the waist sex ed, you know, as opposed to, you know, whole body, right? Our sexuality doesn't just lie beneath our belts. That nurtures communication and decision-making, critical thinking. It really allows us to explore our values and attitudes, and really kind of shifts away from this kind of just like, you know, this is what happens if you have sex, you'll get STIs and you get pregnant, and that's the end of it. So also, as we get into some of this data, I just, Brittany's going to get into some of the data, and then Dr. Ashley Hill is going to get into some more of this data. I really just want to put this out there too, is to be careful as we talk about this, and looking at some of these disparities, that we don't put Black girls at fault for this. And I feel we live in a society where that often happens, where the victim blaming is kind of our lead off. When we share these disparities, we know that we're not showing the whole picture. When we look at STI data and teen pregnancy data, it's not the whole picture. It's really not showing some of the other things that we sometimes see, you know, as far as healthy relationships and things like that aren't as easily measured and often aren't reported on. And really even looking at the way sex ed is funded in this country, there's a lot of money towards teen pregnancy prevention, less now under the Trump administration. But there's not a lot of money to support teens who are pregnant and are already parents. So really kind of shifting this paradigm of how we need to support our students is really, really important. So with that, I think we go to the next slide.
All right, so what we're going to do is share just a little bit of some of our findings from a report that we put together that everyone can access. It's available on the Gwen's Girls website. The title of the report is Black Girls and Sexuality, Education, Access, Equity, and Justice. So we, as Dr. Elliott mentioned, from the beginning of the Black Girls Equity Alliance, we split into 4 working groups, and the Health and Wellness Working Group was one of those initial groups. And right away when we met, we talked about a variety of topics we wanted to cover within that realm, and reproductive health and sexuality and sex education was came up to the top right away. So we spent a couple of years as a group putting together a survey to learn about what's happening in the region. We've right away when we were talking to providers of sex education, it was pretty clear that there were a lot of things happening and that there wasn't one source of information. So there wasn't one person that we could call at a school district and say, give us a description of the sex education that you're offering in your school. That we if that resource exists and someone knows of it, please tell us, because we couldn't find it. So we basically decided that was the first step that we needed to do, was paint a picture of what was happening, mostly in Pittsburgh, but the broader Pittsburgh area. So we created the report as a community group, and then surveyed both internal providers and external providers. So internal providers are teachers, some nurses, anyone who's like a member of the school system who's offering sex education, and then external providers are organizations that come into the schools to offer sex ed. So this is some of our key findings, and then I'm just going to show, again, a little bit of the data, but all of y'all have access to the full report online. The, I think, really important kind of thing we suspected, but came out in the data as well, was that comprehensive sex education in the county is inconsistent and non-systematic. And part of what we found was that even in a given school, you couldn't necessarily predict two students in the same school weren't even getting the same sex education. So, so really hard to figure out what was happening where, and a lot of inconsistencies across the county. That it is offered by both internal and external providers, and even in some schools have both happening, right? So some kids are being taught by a gym teacher and some students are being taught by an external organization. And we weren't able to find a clear explanation or path of like why that was happening. The type of education offered did vary based on the ethnic makeup of the schools. It's really important, and I'll talk a little bit about some of that data. In particular, schools that are predominantly African-American students, their internal providers were less likely to use a structured curriculum than schools that were not predominantly African-American students. Next slide, please. So we ended up surveying 33 internal providers and 20 external providers, and that covered more than that number of schools because some of the providers go to multiple places. Again, predominantly in Pittsburgh, but not just in Pittsburgh. We reached a number of different areas. We found that most of the sex education that's being offered is happening either in middle school or high school, and a really small percentage in elementary school, which is, I think, one of our areas of concern that we really do need to be talking about healthy sexuality, relationships, our bodies, starting elementary school. There's age-appropriate ways to be doing this. We also, because throughout all of our work at BGEA, we focus on the voices of youth. And so we did a number of focus groups to ask Black girls in particular about their experiences with sex education. So we have data throughout the report of their own voices about their experiences. Pretty consistently, they told us that sex education was similar to what we found, kind of inconsistent. Some of them said, "Oh, I've had a really great experience." Some of them said, "We've learned nothing in our school." Next slide. So structured curriculum. The reason that this is important is that without a structured curriculum, we don't really know what is happening. It doesn't necessarily mean that not every structured curriculum is great, right? But a good structured curriculum based on evidence-based practices, culturally responsive, and adapted to the student body is the preferred approach. And so when that's not happening, then it's hard to figure out what is the teacher teaching? Do they know the information that they're providing? How are they responding to questions? Is the lack of a curriculum because of a lack of resources or training? So this was one of the things that we asked in the survey, is if someone was using structured curriculum and what it was. And this was one of the findings that we saw was really different based on the ethnic makeup of the school. So in schools where there were internal providers, so again, these are teachers or nurses, most often health teachers or PE teachers, internal providers, schools that were predominantly Black students were less likely to be using a structured curriculum than in schools that were not predominantly Black or African American. Overall, we did find that a lot of the internal providers are using a structured curriculum, so that makes that demographic finding, I think, even more concerning. So some internal providers have access to a structured curriculum, and in schools that have a higher percentage of Black students, they're not using the structured curriculum. In the surveys, we had open-ended questions, and this was actually one of the things that some of the teachers commented on was a barrier or something that they needed updated material, or they self-identified a lack of structured curriculum as one of the problems. Next slide. So this is a lot of information. I'm going to just give you the basics on it, and then again refer you to the report. But we asked about a number of specific topics that should be covered within a comprehensive sex ed approach, and then we're able to compare what percentage of the internal providers, those are the yellow bars, versus the external providers were offering that topic. So all of the topics were covered by at least one internal and external provider, but some things were much more likely to be covered by one group or the other. So for example, friendship, most of the external providers talked about friendship where less than half of the internal providers did. So even there we could see in terms of topics, some things are being covered by some groups more than others. Next slide. So as I mentioned, youth voices are really important, and we have focus group data throughout the full report. And I think a couple of the pieces that I wanted to call out today was related to what Jose was saying at the beginning, that part of our concern is not just to have what he calls sex ed below the belt, right? But that the students talk too about feeling like sex ed, when it was happening, was really focused on prevention, abstinence, sometimes scare tactics, when really they wanted information about not just how to prevent pregnancy or STIs, but how to think about sex in the context of relationships, not just saying wait till you're older, right? But really talking about how to enjoy sexuality, how to think about sex as an important part of relationships, and that they really identified that as a desire and something that was missing for them. Next slide. Both internal and external providers listed a lot of barriers to offering sex education. They were different kinds of barriers. So external providers, again, are organizations that come into the schools. Some of their concerns were not being allowed to do condom demonstrations. We know actually demonstrating use of a condom is much more effective than talking about it. Time constraints, so if you're given one 50-minute class, you're not going to cover a lot in sex ed. And then issues around who is allowed to participate, if you have opt-in versus opt-out options for sex ed. For the internal providers, there were more questions around access to curriculum, their own training or resources about how to have discussions about sex and sexuality, how to navigate when dynamics in the classroom became complicated, how to address what was developmentally appropriate for the students. And then a number of them specifically named really wanting to better address sexual orientation and gender identity into sex education, and not feeling like they necessarily had the information that they needed or the training they needed in order to do that. Next slide. Then I'm going to kick it back over to Jose to talk about some of the things that we're recommending that what sex education should be looking like.
So I just want to mention too that a lot of what we found locally really mirrors what's happening on a national stage. In a lot of places, we're doing just as bad, if not worse, than a lot of other places. So this is a local issue, but it's also a national issue that we're trying to tackle here. And an interesting thing I just want to bring up that happened when we did the internal provider survey was none of the health teachers that we surveyed that did health education for K through 5 said they did any sex ed, which I assume is not correct. I think it also comes from a place of not understanding what sex ed is in an age and stage appropriate place. So when you talk to a kindergartner, you're not really going into ejaculation and orgasm and sexual pleasure, right? You're looking more about how to communicate personal boundaries and build bodily autonomy. When we talk about consent to a kindergartner, we're going to talk about sexual consent, but consent in a way that they can understand, as far as you get to give permission to who gets to share your toys or who gets to play certain games with you, right? When we look at the issues around human trafficking and child abuse, really having these conversations at a young age with every student, so we don't have to guess whether or not the parent covered it or not, that they need to know how to seek out help from trusted adults and how to understand their own feelings and when they feel uncomfortable and when they reach out to an adult when those feelings come up. It's really, like I said, it prevents all these other things. It's not just about pregnancy prevention and STI prevention when we're talking about sex ed. So honestly, locally, I've had to subversively teach sex ed to those age groups and call it violence prevention, which sex ed is violence prevention. But a lot of K through 5 admins and teachers get really afraid when you say the word sex and then have, you know, in the same sentence or paragraph, you have elementary age students, you know. So trying to get over that barrier of really highlighting what sexual health education is and destigmatizing just the word sex and sexuality is real big. So once again, having this holistic approach, we get to acknowledge all these intersections. So when we look at, you know, who is dealing with the worst violence and sexual harassment and sexual assault, you know, it's often intersection of girls and Black girls, and then Black girls who identify as LGBTQIA. So really making sure that we have Black women and girls at the table, establishing best practices and occupying prominent leadership roles nationally, and I'd even say locally. When we look at sex education, it's very white. There's not a lot of Black folks stepping into these roles or even knowing that these roles exist. And we need to bring people to the table, not just to check off a box, but to really hear their insights and what they need and what they're looking for as far as their education goes. And that also not just goes for education, but also the research behind a lot of these sex ed tools and outcomes. Really have a representation of Black girls' identities in the classroom. Like I said, having Black educators and different genders, identities, and sexualities for that matter. I can tell you right now, when we look for any sort of reproductive anatomy charts or sexual anatomy charts, it's really hard to find one with folks with brown skin, which is an issue. And also just even whenever they do make any sort of curricula focused towards Black folks, it's still often written by white folks. And, you know, they feel that they throw some street lingo in there, then, you know, they can check off the box like, okay, we're being inclusive, you know, which doesn't quite cut it. So we really need to make sure that's designed and adopted by and for Black girls and women. And right now there are some really great people out there doing this work. If you have a chance, look for WACSHN, Women of Color Sexual Health Network. There's a whole network of women who are sexologists, sex therapists, and sex educators. And they even recently released a curricula that's really great. I think it's called Sex Ed Mixtape, I believe. But yeah, and that'll be in there is a resource list that we're sharing, and that WACSHN is on there as well, so you'll be able to find that there. We can go to the next slide. Really taking a strength-based approach, not coming in and just saying, you know, this is why we have these issues, but really looking at all the things that young folks do well. You know, that positive youth development piece is really key in all education, including sex ed. You know, not just coming in and saying like, okay, like, you know, y'all are poor, y'all are Black, you know, you're getting lots of STIs. Like, that's not really a strengths-based approach. You know, really coming in and letting them know about how strong their minds are, how their ability to shift and change and adapt is way greater than most adults who are talking down to them most days, you know, and really bringing out and highlighting the things about them and their identities that can empower them to have power over self and their decision making. Really being trauma aware and by oppression in all its intersections. So once again, we look at these different intersections between gender and sexuality and race and class and ability, all types. There's so much, you know, to really make sure that that we're being aware of that. And really change the research and evaluation metrics, move beyond just teen birth and STIs. Once again, that does not paint the whole picture, and it kind of goes away from what that strengths-based approach is when we just stick to the negative outcomes that we're seeing, and really try to show how we can reach some more positive outcomes. We'll go to the next slide. So once again, we're going to share out some resources for you all, and that's a very small step anybody can take. Is just educating themselves and then having conversations with friends and family members to educate them as well, so we can kind of get this out of just a small niche area, and also empowering parents and other caretakers to internalize some of the information that you can get through these resources and use that with the young folks that you work with. or that you, not that you work with, that you care for, whether it be your nieces, nephews, children, or whatnot. Yeah, if you want to add your email to the Google form, you're interested in collaborating. One of the recommendations we have at a report is to make sure that we have a steering committee for the professionals doing this work. So we have folks from all different walks of life. So, you know, we don't just need the public health folks and the social workers and the educators at the table. You know, we need people who cook for a living, parents and aunties and grandparents and great-grandparents and neighbors to also be at the table to inform us of the things that maybe we're missing when we kind of get stuck in our world of academia and just being practitioners of sex ed. Next slide.
So that was your last slide, Jose.
All right.
Concluding thoughts from you and Brittany?
Once again,
Oh, go ahead, Jose.
once again, I just really want to highlight some of the bigger issues that we're kind of tackling right now. Like I said, trying to make sure that we have K through 12 sex ed, really getting folks to understand what this work is and what it means, and highlighting that folks who are actually teaching sex ed need to be trained the same way a math teacher needs to be trained and an English teacher needs to be trained. The curricula is very important, but if somebody already hasn't had good sex ed in their lives, then oftentimes they bring in their own shame and stigma and things into the classroom, which can be very counterproductive. So we need to make sure that folks who are doing this work aren't taking it for granted. It's like, oh, it's real simple. I just read out this book, boom, you know, the kids know what's up, on to the next thing. And it's like, we really do need folks that have a deep understanding and internalize some of these values of sex ed inside themselves before they start teaching. So, yeah.
Jose, there's a question in the box that asks, have any Allegheny County school districts adopted full comprehensive sexual curricula throughout all the grades?
No.
That you know of?
No, I'd go as far as to say, if you went to the state, it'd be hard to find.
Right. And I was going to say, I saw that question, and I know Tasha's going to talk about a movement to mandate sex education. But I think part of what we found is that there are schools who have a policy that they are using comprehensive sexuality education, but policy and practice don't always match up. And so that's part of the reason that we did the surveys ourselves. And so I think even as we, even in places that have policies around offering sex education, we really need some people and parents and aunties and to be sort of checking in on what's actually happening, right? Because if there isn't a mechanism that's holding the school districts accountable, they can say, we're offering this, and then who knows, right? They maybe don't always know as a curriculum, you know, as a district wide what's happening. So I think we definitely need the policies to exist, that districts should say that they're going to do comprehensive sexuality curriculum throughout all grades. And then we need ways to sort of check that and make sure that it's happening, and make sure that it's happening in ways that are appropriate especially for our Black girls.
Thank you to Dr. Brinkman and to Jose. A number of the things that you said really stood out, and I know that Tasha is going to get us deeper into how to get involved, so I'll save that conversation for her. But one thing I want to say, Jose, I never thought about how comprehensive sex education is a violence prevention tool, and I think that's so true, and you and Brittany's presentation really highlighted that, especially as it relates to bodily autonomy, something that Black girls are often not given the privilege of. I mean, we can't even put this conversation within a historical context. And when we think about just the generational rape and trauma of enslaved women, and also the way that people like Sarah Bartman were paraded around the world simply for their bodies. And so thank you all for bringing that up. And I just wanted to connect it to a larger historical context. So we're going to switch over now to a conversation about reproductive justice, which ties obviously very closely to comprehensive sex ed. We are going to hear from Ms. Tasha Bonner Johnson. A few details about Tasha. She is the manager for Sister Speak, a youth project of new voices for reproductive justice. She has a degree in criminal justice, but a passion for advocating for youth. And prior to her start with New Voices for Reproductive Justice, she worked closely with the PGH public school system, children and youth services, and juvenile probation as an intervention specialist and a direct care worker for young mothers. Tasha, we are going to turn it over to you.
Okay, sorry, I'm having trouble unmuting. Hello, everybody. So everybody talks so greatly about reproductive justice, and we just didn't actually term it as reproductive justice. So I'm gonna give a little overview of what reproductive justice is, and then some of the policy and actions that we are doing surrounding comprehensive sex education. So the term reproductive justice was developed in 1994 by Black women at the African Women's Caucus in Illinois. And it's a movement that's led by women of color. It's reproductive justice and it's reproductive rights and social justice put together. And it really represents that there are many layers that create barriers as which we Black women face. And without acknowledging these intersectional experiences, we cannot achieve complete health and well-being for our Black youth. So what does reproductive justice look like as a framework and a theory? Next slide. So I'm not going to read off all the slides, but I will read off some of the things on the slides. I'm going to read off the two things that really are important to me when it comes to what reproductive justice is, and that's the right to live free of violence and oppression, which we can see that that's not happening for us, and the human right to control our bodies, our sexuality, our gender, our work, and our reproduction. And that is something that our youth are not being given the opportunity to. So how can we help our youth if we can't even give them the information they need to have control over their bodies and control their bodies and their sexuality? Next slide. So I'm going to read this quote because I think it's awesome, and I think it really speaks to what we're doing here with comprehensive sex education. Comprehensive sex education is one of the most versatile activation tools I've ever seen, from the revelation that that your body is yours alone, to learning how to love and be loved. The education that our youth can receive from comprehensive sex education is a game changer. And it really is. It's way more, and Jose and Brittany definitely spoke on this, it is way more than teaching our kids how to use condoms, but it's about giving them the adequate skills that they need to make the informed, healthy decisions about their lives. Young Black girls don't always have the time to talk about their decisions sometimes, and as many of them have adult responsibilities, they make quick decisions, and sometimes without the mental development and the right skills, these decisions become life-changing. So some of the things that Sister Speak works on are policies, and we work on to fight for policies and to change policies that are affecting our overall health and well-being. So some of the legislation that we are working on right now currently. Next slide. So as we talk about House Bill 1586, I want to reiterate how Jose and Brittany were talking about what exactly comprehensive sex education is, because I want to make it clear that what PA requires and what comprehensive sex education are on completely different levels. So the House Bill 1586 is policy to define what sex education should be, and that all PA schools should mandate that they give students comprehensive sex education versus sex education. So there's already a policy in schools that schools are supposed to give sex education. But as we see, sex education is nothing. So quickly, PA requires schools to provide STD and HIV and AIDS education. It must be age appropriate and stress abstinence. That's it. That's all that PA requires a sex education program to be. So as they talked, comprehensive sex education is way more than that. We want it to be age appropriate, medically accurate, STI information, of course, but alcohol and drug use, healthy relationships, local resources and legal rights, affirmative consent, sexting, and it also has to be inclusive to all identities. Next slide. So another legislation that we are working on is the Real Education for Healthy Youth Act. So as Jose said, and we'll have in the resource box, there are many programs who are educating on comprehensive sex education. And not only do we need to change what sex education is to PA, but we also need to support the programs that are already doing this work. So the REA Act actually is legislation that will give the CDC and other entities like it permission to fund programs and or school programs to conduct comprehensive sex education. So until schools step up, these programs are all our kids have. And it's very important that we help sustain these programs. So this policy would give funding for programs that do sex education. Next slide. So also in my time working with policy, I've learned that there are many policies about the same thing that go out to different levels. So the Youth Access to Sexual Health Service Act is pretty much the same as the REA Act, which is granting services to award grants to programs who are giving comprehensive sex education. So that's the same that this policy would do. Instead of the CDC, the YES Act would give the Secretary of Health and Human Services the ability to award on a competitive basis to eligible entities. Next slide. So now, as I said all that, and I'm sorry because I always speak a little fast, but what actions are happening? So all these policies at this time are in their early stages. And what could be done to help further some of these policies? On a state level, Sister Speak Youth Project is working with other entities we have webinars that are coming out that are leading up to a virtual lobby day where we will garner support for the House Bill 1586 and try to push it into its next stages. Right now, it is all Democrats who have signed on to this bill. And I don't know if many people know, but in order to get bills and policies passed, you definitely need both sides. So we are signing up and setting up to do vast amount of webinars to push the House Bill 1586 and why it's important for them to move this to the next stage. And then as a more local level, of course, with the Black Girls Equity Alliance and the things that we are doing here, to just stay in contact with the people on these levels. You can become an advocate for your child, write letters to your legislators, encouraging them to support these bills. Attend school board meetings, talking about why comprehensive sex education is important. Invite a program to your PTA or to a space where you are with other people, parents, teachers, students, and talk about comprehensive sex education and really get out questions that you might want to know, or just to figure out what it is that we're really trying to push. And of course, always to donate to local organizations that are doing this so that we can keep up the fight and continue to be able to do this work. Also, with the resources, I have put down how to write a letter to your local legislators, how to testify at a public hearing, and there's paper and everything that you need to be able to write the letter and send it to your legislators about comprehensive sex education and why it's important. That's my last slide.
Thank you so much, Tasha, for that, especially with sharing ways to get involved. I mean, as you were speaking, I kept thinking to myself how much work we have to do as adults to even be able to show up responsibly for our young people. And speaking of showing up responsibly, we are going to hear from Dr. Betty Braxter, we're going to hear from Ashley Hill, who is our next speaker, and she's going to talk to us about both Allegheny County STI rates and about a very innovative program that she is leading. Let me tell you a little bit about Dr. Hill. She is currently a postdoctoral scholar with the Department of Pediatrics, Division of Adolescent and Youth Adult Medicine at the UPMC Children's Hospital of Pittsburgh. As a reproductive epidemiologist, her research examines health disparities and the co-occurrence of social, environmental, and biological factors that impact sexual health and reproductive morbidity. Currently, her projects investigate the implications of relationship violence, structural inequities, and systemic oppression on girls and women's reproductive health. I'll turn it over to you, Dr. Hill.
Awesome, thank you. So I'm gonna kind of give an overview of some of the STI rates in Allegheny County and kind of an emphasis on the impact of STIs within Black women in this age group that we're interested in. But I definitely want to preface my very brief data overview with something that Jose said earlier, which is that disparities really don't explain themselves. And while we may see a lot of disproportionate rates, it's important for us to understand that there are many structural and systemic factors that impact the numbers that we see. And so my mission as an epidemiologist, and particularly focusing on women's reproductive health and examining data, is centering on the experiences of the individuals that we're trying to understand as far as examining data. And so I really want to preface my slides with that, because I know sometimes they can become a little bit heavy on, wow, there's a lot of rates of this in a specific population. But I'm going to definitely bring it back to discussing some of the things that Latasha and Jose and Brittany have talked about as far as programming, and then really being mindful of what Aja and what Shalay discussed about centering on experiences and really lifting up the experiences of the young people that we're trying to serve. So briefly, I'm going to go over on this first slide, just sort of showing you what STI and HIV rates look like in the county. All of the data that I'm presenting today is made publicly available through the Allegheny County Health Department, and it's the 2018 STI STD data report. So what you'll see here on this first slide is a breakdown of each infection that's reported to the CDC and also to the health department by public and private providers throughout the county. And you'll see is that predominantly we have pretty much a disproportionate impact of chlamydia, gonorrhea, and HIV cases among Black individuals in our county. And you can go to the next slide. So specifically looking at chlamydia cases, which is one of the infections that I primarily have focused on, we see that females or women have a disproportionate impact of increased number of cases as far as the overall, and that's denoted with the blue line. One of the things that I think is important to understand when interpreting some of this data is that typically young women, and especially reproductive age women, have more opportunities for screening. And there are many more implications for screening and, again, opportunities for screening for young women than there are for men. So at times, this data does have to be interpreted with an eye and understanding that fact. So the next slide. And again, we can see this breakdown of chlamydial cases in the county by age. So we see that there is a disproportionate impact or disproportionately increased cases of chlamydia among young women in the 15 to 19 and 20 to 24 age group. One of the reasons, again, that this is so important to understand as far as interpreting the data is young women in this age category are starting to go for reproductive and annual visits for gynecological checkups, and they're also starting to have these, they're starting to have testing at this time as well. So there's more opportunities for testing sometimes than there are for young men. But you do see on the male side that this similar trend in this younger age group is happening, but we may just have less cases. So forward for me with the slides. And then again here, you can see specifically looking at our race and gender, specifically looking at a Black and white disparity. Again, chlamydia disproportionately impacts Black young people in the county. So we're really focusing on understanding how we can better incorporate comprehensive sex education, as was previously discussed, opportunities for screening and testing, opportunities for testing partners, and reducing reinfection. Next slide. And here we just have, again, a breakdown of our rates specifically. So if we're looking at the number of cases that are reported, in the far left column, we see the estimated population of that's being impacted in that middle column, and then the case rate, which is there in the left column. And again, this is just giving us an overview and a description of what this looks like among the cases that have been reported with the population estimates. Next slide. So here again, we have an overview of what chlamydia cases look like. It was nice to see that for young women, or for women generally in the county, we saw a decline in the number of infections for chlamydia over the past few years. but a bit of an uptick in men. So still trying to investigate what exactly the phenomenon may have been there. But generally speaking, we do see less gonorrhea cases than we do see chlamydia. However, there is a lot of evidence to suggest that those cases can be concurrent with chlamydia. And so really being mindful of that when we're talking to our providers about screening. Next slide. But further, what we're able to see is that this disproportionate impact in young people remains, just as it does with chlamydia. We see that the case rates are about the same. Again, high impact in younger women, also high impact in younger men, and really wanting to focus on understanding how we can best offer appropriate services and increase screening among this population. Next slide. Thank you. And then again, we have the case rates, and we don't have to go into that too much. And then, so this is just giving a description of what syphilis looks like across the county. We typically don't see syphilis having too heavy of an impact within the age group that we're interested in. Syphilis does, however, have a very strong disproportionate impact in men who have sex with men. And so when we are really interested in understanding the experiences of our gender diverse or LGBTQ+ young people, it's important to really understand and discuss what these types of experiences may be as well. Next slide. So for our young women, again, we can see that the impact is not as great as it is in young men, and particularly men who are in the more young adult, moving into the adulthood age group. But still very important to discuss what syphilis looks like, early syphilis rates. This is the time when syphilis is the most infectious, and really important to capture and do some of that tracing and partner services during this time as well. Next slide. And again, we have some case rates here, and we don't have to get into that too much. We can refer to the report, but I'm just showing that syphilis here has a heavier impact among white individuals, which is a little bit of a change from the earlier rates that we discussed. And then overall, I think Allegheny County has done a very good job with testing and providing partner services and integrating into treatment for individuals who are HIV positive. So you can see here pretty much over the last 10 years or so, there's been a pretty consistent decline in the number of individuals who are HIV positive in the county. Next slide. And again, this impact in our young women age group of interest is not as much, but we do see that the 20 to 29-year-old age group in young men is important. And so that has implications, obviously, for our girls and individuals in their social networks. And so it's important to understand the context of the data here. So that's why I just wanted to present it here. So next slide. And again, we have the population estimates and case rates by gender and then also by race. And then again, as I referred to earlier, it's important to understand too, sort of like what are the descriptive characteristics of the individuals who are positive. So in Allegheny County, we see an overwhelming majority of the individuals who test positive for HIV are men who have sex with men. But of course, that has implications for all of our youth. And so we want to be mindful of that again when integrating some of this, our efforts to address these issues. Next slide. So briefly, again, we see that chlamydia and gonorrhea predominantly is heavily concentrated among the age group that we serve, and that particularly the burden of chlamydia and gonorrhea is highest among our Black young women. While syphilis is certainly an issue, we do see that it is predominantly among white men who have sex with men. And again, so is HIV, but we've really done Allegheny County's done a great job with a decline in those overall new infections over the past 10 years. And so really trying to reinforce and continue that work within the county is what we want to see. Next slide. So, and this is a little dense, so I apologize in advance, but this is a program that you heard about earlier, that through the UPMC Children's Hospital and the Division of Adolescent and Young Adult Medicine, we've been able to have the opportunity to implement in several of the Pittsburgh neighborhoods. And this program really is targeted towards violence prevention and having a gender transformative approach, which really addresses and centers on reproductive justice, comprehensive sexual education, and really understanding what healthy sexuality is. Just as Jose said, really sexual education is violence prevention. And so we've really integrated a lot of that in this program. So what it does, the key components of Sisterhood 2.0, which is the name of the program, is that it really analyzes gender and social norms that can influence and condone sexual violence and relationship abuse. It centers on sexual health promotion, and it really improves and is intended on helping young women understand what it looks like to be a bystander and that can intervene. And so it's important for us to really help young women understand what sexual violence looks like, and to be able to address it within their social networks. So the curriculum specifically, again, explores gender and power, understanding violence in relationships and what that looks like, being able to identify it, addressing anger and conflict, specifically, again, focusing on healthy sexuality and what that looks like, what it means, sexual and reproductive health and rights, integrating reproductive justice, and really a commitment to the groups that they're engaged with. So I'm excited to have Jose here because what I did in my analysis piece was really look at some of these preliminary outcomes in addition to the feasibility of us being able to implement it. One of the key hallmarks of sisterhood is that a trusted adult facilitator leads this group that is usually of 10 to about 20 girls. We try to keep the groups pretty small so that they really have the interconnectedness. And it's a session where the girls meet over 8 weeks for about 4 hours per week. And they really have lots of very open conversations about these topics. They're guided by the curriculum, but it's really centered on the delivery from the facilitator and the facilitator's connection with the young women. And so Jose has been our main facilitation trainer, but he also has delivered the program several times on the side that we have for young men, and can really speak to what some of the positives have been and what we think we haven't been able to truly capture in the data, but really has centered around the success of the program being the connections with the young women amongst each other, and then the connections with the adult facilitator. So one of the things that I do want to highlight quickly that we found, that although this program is really centered on violence prevention, we saw that the improvements that we were able to measure were really in the young women's ideas and attitudes related to condom and contraception use, their self-efficacy to use effective contraception, and to be able to negotiate condom use with partners. It seemed that they came away with really feeling strongly about being able to do that in their relationships, and feeling having been able to really identify where they are and the places that they wanted to improve on. So Jose, if you don't mind, I think it would be great if you could tell us a little bit about the sisterhood program from your perspective, and then also, kind of some of the things that you feel like we maybe have not been able to fully capture in the data analysis, but have been some of the successes with the young people in the groups that you've worked with.
Yeah, thank you. It's, one of the best parts about just any of the sex ed stuff I've done over the years has just been watching kind of that transformative effect you see in the classroom when students can get the opportunity to actually trust the adults who are speaking to them, because it's not just kind of this like fear factor education of just like, you're going to get AIDS and die, like we're actually like talking about pleasure and relationships and all that is really great. And sisterhood is by far one of my favorite groups. So before sisterhood started, I had facilitated for manhood for a number of years, and the guys are great. I love them. The facilitators are great. The students are great. But in case some of y'all don't know, we have a real problem with with healthy masculinity in this country. Like there's not enough of it. As you were talking, I was remembering the one time we brought the two groups together, the boys and the girls, and the facilitators and the girls in the sisterhood group were just shocked because of the homophobia and transphobia of the guys, which I kind of took for granted because I'm used to that. Talking to young men, it's almost a survival mechanism for young men to cling to these toxic ideas about what being masculine is, right? Of you got to be tough and you can't cry and you got to be straight and all these different things. But the women who are facilitating for sisterhood do such a good job, and they really internalize what I feel is so important, not just in sex ed, but all education, which is really fostering those relationships. I've done my own kind of peer education program for a number of years that we every year would study how effective it was. And I would really feel like I let folks down because sometimes the students didn't learn as much about certain topics as I would have hoped for. But we kind of shifted the way we look at it sometimes and really looking at what relationships are like. Because what we find is when that relationship is built, the students trust you. And then when the issue comes up, they don't need to remember all the information. They just need to remember that they can contact you and get what they need, right? So if there's a pregnancy scare, if they're unsure about the way their partner's treating them, if they're having just an issue at home or whatever it may be, that's like totally away from what this is, right? Maybe it's just food insecurity or whatever. But if that relationship is built, then we have an ability to really support students in the ways that they need and not the ways that we just anticipate. So really seeing the sisterhood of the sisterhood program has really been a real bright spot in the work that I've had the pleasure of doing over the years. I mean, it's truly transformative to see what happens when there's open, honest communication, which I feel for a lot of students, it takes a while for them to adjust to that because their first thought is like, oh, eye roll, oh, they're about to tell me like, don't have sex till you're married, or any sort of sexual pleasure. That means that, like if you're hooking up, that means that you don't have self-control and you must be a slut or something like that. And that's so far from what these facilitators bring up. But that's kind of what the expectation is, because that's what they've been hearing their whole lives. So kind of building that space for that is so key. And it's so like, I want to say it's magical, but it's not magic. It's really just y'all doing what y'all do best and getting the work done. But it feels really magical just seeing that transformation in class like before your eyes and seeing that change. And once again, like not to throw the guys under the bus, hashtag not all men, but like, I feel the male students and the male facilitators really struggle with some of this information and internalizing it because, especially when we look at violence prevention, a lot of the men have a real hard time getting past the whole idea that men have to protect women, as opposed to men need to not abuse and oppress women, right? It's not our job to protect women. Women can protect themselves. We just need to not hurt them. And also, afterwards, it's because we've also been taught the same lessons that the young men have been taught. It's hard for a lot of men to model vulnerability, right? It's most men and boys really want to come from a place of like leadership means that you have to know the answers all the time. And to ask a man who's like a coach and takes these leadership roles all the time to kind of take a place of like, oh, I don't actually know all these answers. I'm just want to have a conversation. Can be a real hurdle sometimes. But with that said, the guys do a great job. Once again, not throwing on their bus. I love them. I love all the facilitators there.
Thank you, Jose. So yes, I appreciate you kind of sharing that. And I'm going to conclude again with just saying that disparities are really not as much about behaviors as they are about systems. And I think the thing that we really are trying to do with sisterhood is help girls identify these systems in ways that they can reject them, obviously, but also integrate more healthy and sustainable practices in their own lives. So I will conclude with that.
Thank you, Dr. Hill. We appreciate that. And I have to say, I was joking earlier that I am an attorney by training, but I'm a social worker / mental health practitioner in my head. So this is not the first time that I have heard this idea of positive relationships being key to youth development. And so I'm really, really grateful that that's something that came out in your research and that we know needs to be at the core of comprehensive sex education. So next we're going to hear from Dr. Betty Braxter, who is going to really give us a chance to dive deep into maternal and child health disparities during COVID-19 to kind of culminate our entire conversation for today. After Dr. Braxter's talk, let me just say very quickly before I turn it over to her that we will have a brief Q&A period. Please continue to use the either chat box or Q&A box. So Dr. Betty J. Braxter is the Associate Dean of the Undergraduate Program and an Associate Professor at the University of Pittsburgh School of Nursing. That means she's very busy. She's also involved in the maternal child courses offered to undergraduate and second degree students. Additionally, she works with students in the School of Nursing's 2 graduate nursing programs. As a certified nurse midwife, she has managed and provided care to women across the reproductive life cycle in the United States and abroad. Dr. Braxter, turning it over to you. Please just give me a signal when it is time to change our slides.
Well, okay. First, I'm going to take like 15 seconds for people to do this. I want you to close your eyes, take a deep breath in through your nose, open your mouth and blow it out. We've been listening to wonderful presentations, but we just need a chance to blow out, relax for about 8 seconds, 7, 6, 5, 4, 3, 2, 1. Now we can move on. I'm going to start talking about health disparities. We've heard the passion of all the previous presenters. And this passion is very noble and is needed when we think of health disparities. Essentially what they are, when you think about it, is a difference in outcomes. We've heard data that gives outcomes as it relates to sex ed, as it relates to STIs, differences in outcomes, and as importantly, differences in care. I wish I could share with you that within the healthcare arena, the disparities do not exist. They do. And as you are able to see on this particular slide, many of the factors associated with these disparities are the result of primarily the final areas inclusive of racism, implicit bias, and discrimination. These other factors listed are a part of what we now know and in our community have known for a very, very long time. They're now being couched under the term social determinants of health. Where you live, your neighborhood can determine actually, and the environment in which that neighborhood exists can determine your length of life. And we know that also absence of jobs, poor quality schools lead individuals not to be able to aspire and become the best that they can be. If we would consider what this country could have been and can still be if everyone was able to aspire to their best potential, we would now be thinking and moving quickly with many more individuals involved in discovering a vaccine or discovering other strategies to combat the COVID virus. That's the result of health disparities. It impacts all of us, irrespective of race, irrespective of SES, irrespective of education. There was a somewhat rude awakening for those of us in the healthcare arena, for some of us in the healthcare arena, when the following document was published, and this was published through the Institute of Medicine about 20 years ago. And if you look at the title, it begins with unequal treatment. Unequal treatment. Unequal treatment leads to health disparities. Furthermore, the title tells us what healthcare providers need to know about racial and ethnic disparities in healthcare. They do exist. Those of us in healthcare, organizations who work with those of us in healthcare, we have to be advocates to reduce the health disparities. And the arena in which I love and which your director talks about my profession and her profession as being the best profession in the world, we have to be at the forefront of reducing and eliminating these health disparities. Next slide, please. On this slide, this is a piece of heavy lifting. Every day, 2 women, typically women of color, and every woman is a woman of color, but typically, primarily Hispanic and African-American women will die of a pregnancy-related problem every year. And that's been for more than a decade. That equals about 700 women we lose every single year. The numbers are slightly down now, but we're still hovering around that 700. Furthermore, about 50,000, and I did say 50,000 according to some research, 50,000 women experience near misses. A near miss is they were ill enough that it could have led to death. Again, African-American women are disproportionately represented. And that's the maternal mortality for actual deaths, maternal morbidity for injuries sustained during the pregnancy, during the labor, delivery, during that first month of, and I have background noise because I'm near a healthcare facility, that first year postpartum. There's differences in sexual reproductive health needs, as well as for many years, needless to say decades, African-American women have had a 2 to 3 times higher risk of having a preterm birth. You see in this picture a grandmother and a grandchild. The grandmother is Mrs. Irving. Her daughter was an epidemiologist at NIH working on health disparities. She was not low income. She had a PhD. Her risk of death was higher than the risk of a Caucasian woman with a high school education. And Shalon Irving died as a result of a pregnancy complication. As a result of these kind of issues, in 2018, ProPublica and New York Times highlighted 120 women who died as a result of a pregnancy complication. It's called the Lost Mothers series. Those of you working with organizations need to look at it because these women are all across the board, that they lost their lives primarily related to pregnancy. That was the key, pregnancy. And pregnancy complications through that first year of the postpartum. As a result of the publicity, by the end of 2018, beginning of 2019, the House of Representatives did pass the Maternal Mortality Act. That means that all states should convene a maternal mortality review board. Those type of review boards have been in place on the West Coast, California, Colorado, Nebraska for at least 2 decades. As a result of the work of maternal mortality review boards, particularly ongoing, there's been a drop in maternal mortality rates in that part of the country. The Commonwealth of Pennsylvania just developed a maternal mortality review board as of the fall of applications went out the summer of 2019 or 2018. and they convened one of their first meetings in the fall of 2018, and that work goes on now. This is a committee that will look at any maternal death and make recommendations. How can we do better? The three areas, and some of your panelists have talked about this, the three areas that have been associated not only with maternal deaths, have been associated with also other health disparities in my arena are systems, providers, and then education of our clients. It falls on us to help clients to understand, because they didn't make it through 20 years without knowing how to do something. So it falls on us to figure out a way to help them expand them knowing how to do and how to respond to educational aspects as it relates to their health. There is a glimmer of hope, as your panelists have talked about, some variations in STIs, some differences in sex education, with the hope that that's improving, and it is. It's incremental. We've seen for the past couple of years that we are no longer the adolescent group that has the highest adolescent pregnancy rate. That is here in Pittsburgh, but that is not nationally. And when you look at the national data, the 2018 natality birth data from the CDC has Hispanics as number one, African Americans as number two. It's nothing to be, we can shout and say, okay, it's done. It just says that we are making progress. And the last rate for the 2018-2019 is not out yet, as far as I know. There had been further drop by at least 4% in this rate. So some of the information you hear, if you don't have the data to refute it, you believe it. So when you look at data for adolescent pregnancy, we are getting better, much better than the 1990s. And some of you on this webinar were around in the 1990s. We definitely had the highest adolescent pregnancy rate. And it was because of some of these issues, SES, education, discrimination, racism, all of those factors fed into that. Next slide, please. I'm going to talk for a minute or two about COVID. We are consumed with COVID, but COVID didn't generate our health disparities. They were around long before COVID-19 emerged on this side of the pond. Anytime you have a virus or infection, you always worry about your pregnant population, because my arena is the only arena, all in healthcare, be it a physician, a nurse, nurse practitioner, those social workers, mental health workers. Our arena is the only arena with biologically pregnant women who always involve at least two people. Your pregnant woman and the fetus the pregnant woman is carrying, at least two, because if you have multiples, it's more. So you always worry about this group. Initially, if you think about it, when COVID emerged, the focus for COVID was typically, and rightly so, typically the elderly, typically those with immunocompromised conditions. That was the primary focus. Very little information on the pregnant woman, very little. There was a dearth of information, almost non-existent information initially. It is getting better. But with any type of virus or infections, the two major issues often revolve around the fetus: preterm births, miscarriages, which are classified as spontaneous ABs, as well as maternal deaths. What we do know about COVID-19, it has a crown-like structure, but COVID-19 is very similar to SARS. Some of us remember SARS in 2003. SARS was more a European and Middle Eastern problem that for pregnant women resulted in increased spontaneous ABs and preterm births. We had very few cases of SARS here. but the structure of COVID-19 is very similar in terms of one of the enzymes that were found with SARS is the same enzyme that we find with COVID-19. And like SARS, COVID-19 is a respiratory problem. And the symptoms for COVID-19 typically include fever, coughing, GI upsets, headaches, even rashes, change in taste. Those symptoms are on the CDC website and on the Allegheny County website. These are symptoms that we should be sharing over and over and over again with all individuals we know, and specifically with the pregnant woman, because we still do not know the full effect of COVID as it relates to pregnancy. As I shared earlier, and will say again, we have limited information as it relates to the impact of COVID-19 on pregnancy. Next slide, please. We'll talk about COVID-19 and pregnancy. So even with that limited information, most of the information came initially from, I'm sure you know, from China, because that's where we see the emergence of the problem. And it was difficult to transfer that information here to the United States. Different population, different treatment methodologies. We now have data here in the United States, beginning probably the end of May, that looked at small cases, 1, 2, merging of several studies and what is known as a review, to give us some glimpse of the impact. As of 2 days ago, we had a larger review with more individuals. So I'm going to summarize for you what the larger reviews from the CDC and the most recent review that is in Emergency Pediatric Journal. What are they saying about COVID and pregnancy? Number one, the symptoms of COVID-19 among the pregnant population is just like symptoms among the non-pregnant population. Fever, cough, rashes, problem GI, headache, but with the pregnant clients, they typically they reported less frequent headaches compared to their non-pregnant counterparts. Erring on the side of being conservative, most pregnant clients who are diagnosed with COVID are hospitalized. They are placed in NICUs or intensive care units and placed on ventilatory support, breathing machines. And that is a very conservative treatment pattern compared to non-pregnant women. Typically, the studies are sharing, and that is happening here in the Pittsburgh area too. Pregnant women suspected of COVID or pregnant women diagnosed with COVID are more likely to have cesarean sections. Another maternal health disparity arena. African-American women prior to COVID had higher levels, or the rates of C-section exceeded the rates of other ethnic groups. However, the risk of death among pregnant women and non-pregnant women were similar. The literature so far, just in the States, shows a very small number of women dying as a result of COVID-19. And then you have to think, was it COVID-19 or was it associated with some of the other aspects of maternal mortality that African American women face? Of interest and most troubling for those of you out there, young women and those working with young women, is this inconclusiveness about transfer of COVID in utero. Can the baby get COVID in utero? Prior to about a day or two ago, I would have said there have been only a few cases of that occurring. But we have, according to studies, at least one study, it's a case study with a 23-year-old in Paris They looked at amniotic fluid, that's the bag of water fluid. They looked at cord blood. They also evaluated the placenta and found the presence of COVID, and the baby had COVID. Baby was in utero. So there needs to be more data. And there was another case, I think, in Texas. Similarly, one of the people at the McGee Women's Research Institute with that case in Paris said, it seems pretty convincing that it was an in utero transmission. This is going to be another issue that we will need to face as it relates to COVID and pregnancy. Next slide, please, as I wrap to close. Next slide.
Thank you, Dr. Braxton. Yes, we are trying to have time for a Q&A, so thank you for wrapping up.
Okay, do you not want me to talk about changes in care?
If you can do so briefly, yes.
Oh, yes, I will. Telehealth is now in place. You will have pregnant women reducing the number of prenatal visits. Typically it was 6 to 10. Now it may only be, typically it was 10 to 12. Now it may be 4 to 6, just depending on their risk. There's more grouping of tests together so we can do many different things at the same time. There will be testing prior to delivery to determine whether or not the client has COVID or has been around a known COVID patient. And some facilities here locally are limiting the number of clients, a number of individuals that can be in the delivery room when the person is delivering. The next slide, and this is the last one. Here are recommendations. Number one, share with everyone the CDC guidelines in terms of signs and symptoms of COVID, in terms of mitigation strategies, wearing a mask. A number of us in our community are not wearing masks, and they are not young adults. Young adults and young people will follow what we do easily. Number two, if you know of someone who's pregnant, they should be in contact with their healthcare provider. They should be talking with them about any signs and symptoms of COVID if it occurs. We should be really advocating all organizations for ethnicity and race data. It took 1 full month after COVID before we got any ethnicity and race data. We are seeing race and ethnicity data in the Allegheny County Health Department dashboard, but there is very limited data as it relates to pregnancy. Very limited. And that is dissemination of data locally, state, as it relates to COVID and pregnancy. Others have talked about local organizations to work with, New Voices, your own organization and other organizations so that we can push for women health and the health of their babies. One quote, which I think all of us need to realize. During the Maternal Mortality Summit that was at NIH the summer of 2018, one of the presenters says, this is what we should be chasing. We should be chasing zeros. We should be chasing zeros for maternal disparities. And we should be chasing zeros for COVID. Thank you. And I think it's time, very much time for questions. Thanks.
Thank you so much, Dr. Braxton, for that presentation. Kathy, would you mind jumping in to field the questions that are in the Q&A box? For some reason, I'm not able to open that.
We don't have any new questions. I think this was back when Brittany and Jose were presenting. It was a question about a book. So has anyone read the well-written resource Sexual Citizens book by Jennifer Hirsch and Shumas Khan? I thought it was a useful and practical. It says more geared for college age, but knowing these experiences start much earlier. So that was, so have you all read that book or know about that as a resource?
I'm in the process of reading that book. It's an excellent book. It's well written. It's easy to read, and I would encourage those of you who are working with girls to read it because it talks about sexual citizenship. It's funny, it's sobering, and I would strongly recommend that you read it.
Thank you.
And
So
we
I don't
will
think that there were any other questions in the chat box either. So we're pretty good on that.
Okay, perfect. Well, in that case, Kathy, I'll turn it to you to wrap things up. It is 5:01 on the dot. Let me share my screen one more time, you all, because we do want to bring up the titles of the last webinars that we will have as part of the series leading up to our conference.
Dr. Elliott, I'm going to need to go because I have a town hall meeting that I'm supposed to be.
Thank you very much.
Right now.
I appreciate you
Thanks, everybody.
participating.
Okay, bye-bye.
Bye. So thank you for pulling that up, Tashara. As you all can see, we have 2 additional webinars coming up on August 13th. Same time, it will be about Black girls' experiences with bullying and sexual harassment. And then we'll round off this series on September 10th, looking at kind of tying into what our upcoming summit is focused on. She Matters, Black Girls and Gender-Based Violence. Just also want to do a quick plug for our 5th Annual Equity Summit, which will be happening on September 24th and 25th. You'll have more information coming out. Because of COVID-19, we had originally planned to have it here in person at a hotel, but now it's going to be virtual. And we are planning a week-long series of events and activities. And so we're so excited, and also excited to have our keynote speaker, Ms. Antoya Brown-Long, who will also be a part of our virtual experience. So without any further ado, we try to stay true to the time. If there are any questions, you can still feel free to put them in the chat box, and we will make sure that they get answered. The information, this video, this recording will be shared along with any of the information that was shared during this webinar. To my panelists, I would like to say thank you very much for your time and expertise and just your just collaboration in addressing these issues that impact girls on a daily basis. I also want to thank those behind the scenes, those with Motor Mouth Media, Multimedia. Thank you very much, Heather and team. Appreciate your support. And also wanted to recognize Southwest PA Says No More. They are a collaborating supporter of this work. So thank you very much. I appreciate it. And I look forward to seeing you all in August.
Bye, everyone.
Bye, everyone.